I had a great opportunity to meet with some of you last night and have a lot of discussion around some of the topics we'll be talking about today, some of the things that are important to you. And I think it's really cool and telling in advance of getting on stage with the group of having those kind of one-on-one interactions and getting a better feel for kind of how to engage and where to meet people where they are. And it occurred to me, you're all probably meeting me where I am, so I'm gonna have to step up to meet you all where you are. Great discussion so far this morning. I am not here to tell you that I think the Inflation Reduction Act is wonderful or terrible or what we could do differently or how it could change. I am here to talk a little bit about how we see the Inflation Reduction Act impacting innovation and how it is impacting dollars that flow through R&D, whether it's through corporate entities like drug and device manufacturers, or whether it's through alternate sources of funding like venture capital and private equity. So, with that, it's been a little over a year now since the Inflation Reduction Act passed. And simultaneously, the American Rescue Plan Act took effect with the passage of the Inflation Reduction Act. So what does it mean for drug companies? What are some of the key provisions? Relative to the American Rescue Plan Act, I think the most relevant ones are the elimination of what's called the average manufacturer price cap removal. So what that means is drug companies historically participating in the Medicare program were capped in the rebate that they would pay up to 100% of the cost of that drug to the Medicare program. Well, that cap's gone now. So it is entirely conceivable that a drug company who discounts to certain customers more than others, which is standard practice in the industry, might owe a rebate to the Medicare program that exceeds the actual cost of that drug, more than 100% of it. The other relevant or most relevant provision in the American Rescue Plan Act is with the temporary removal of this cliff on coverage. Historically, there was a threshold of percentage of income that allowed folks to participate in the program, and once you exceeded that percentage of income, you were no longer eligible to participate. That has been extended, so it's now going to be calculated as a percentage of your income declining essentially with the more money you make. So no cliff, and ideally a more equitable way for folks to participate. Relative to the core Inflation Reduction Act provisions, a couple, I think, really important things to note. One is around the price increases for drugs that exceed the rate of inflation in the market. Drug manufacturers will be indexed on the Urban Consumer Pricing Index as a baseline, and price increases on drugs that exceed that rate of inflation will be paid back to the Medicare program in the context of a rebate. There's been a redesign of the Medicare Part D program, D as in dog, which is the prescription drug benefit in the Medicare program, whereby essentially the goal is to lower out-of-pocket costs for participants. So folks have easier access to participating in the program and getting drugs they need, even at a reduced cost. And there is the one we talked a little bit about here with extending subsidies, right? So that goes hand in hand with the American Rescue Plan Act and essentially eliminating a cliff for folks participating in the program. So this is what it means for drug manufacturers. Note that while the Inflation Reduction Act is not explicitly aimed at drug companies or health industries in general, there is a massive impact for drug manufacturers. And I want to be clear, it's an impact for drug manufacturers, not for healthcare providers, not for pharmacy benefit managers, not really for pharmacies, explicitly for drug manufacturers. And I think that's an important distinction. So when we think about how drug manufacturers run their business, they operate on a portfolio strategy basis, right? They think about the products that they have in their portfolio, right? What is the patient population and what are the drugs that they can offer those patients along a continuum? What are other indications, other uses for the drugs that they have in their portfolio? And really, what does that look like for the health of the business, not just the patient, but for the health of the business? So a couple immediate impacts, when you think about this portfolio strategy thinking as a result is drugs are essentially facing a shortened life cycle, right? So typically you have an investment thesis when you develop a drug, when you bring a drug to market, when you start selling that drug for the life of that product, right? And it's relative to the competition in the market. And in this case, it's relative to the type of drug it is, small molecule versus biologic, right? So a small molecule drug typically is something like an oral solid, like a pill, right? And a small molecule drug is chemically derived, meaning from chemicals in a laboratory. A large molecule drug, a biologic is the term people use, is derived from living organisms, right? More complex to manufacture, more complex to administer typically, and it is essentially the future of drugs writ large globally, right? Those drugs, all drugs, are facing a kind of a different life cycle management outlook now, right? So for small molecule drugs, once a product is commercially viable for 9 years, they are subject to selection and negotiation through the Inflation Reduction Act, right? So historically, it's been the life of a patent, which starts at 15 years, but could be significantly longer. So in the case of small molecule drugs, which again, represent a tremendous amount of volume in drug prescriptions in the United States, which still represent a lot of opportunity in developing complexity for, have a significantly shortened life cycle. Biologics, similarly, much more expensive to manufacture, much more expensive to administer, are also facing a significantly shortened life cycle at 13 years, right? So that's the distinction. There's a little bit of a spread there for some of the reasons that I described. Again, that fundamentally changes the economic thesis on drug manufacturers bringing a drug to market and what that life cycle looks like. The other piece that goes hand in hand with that is shifting R&D priorities. As a result of a different outlook on life cycle for a product in the market, an understanding of how private equity and drug manufacturers will invest. A lot of the success of drugs with a long life cycle helps fund R&D initiatives and other investments that are being made back into the business to develop follow-on indications, to develop therapeutically related products to continue to treat a patient along the continuum of their healthcare journey. And those things are being re-examined, right? Not to say that they're not happening, not to say they're going to cease. That's not going to happen, but they're being looked at differently. The one piece of the Inflation Reduction Act, well, I should say the one very evidently missing piece from the Inflation Reduction Act that we hypothesize is going to have an outsized impact is there is no explicit provision or direction on how drugs can be priced at launch, right? So think about that for a minute. You have historically developed an investment thesis on a drug for a term of usually 15 years at minimum. In some cases, it goes well beyond that, depending on who challenges it, the complexity to manufacture, and so on. If that's shortened or cut in half, one theory here is, well, you're going to have to bake that in to your launch price, right? When you come to market with a drug, now that you're facing 9 or 13 years versus 15 or 18 or whatever the price, or excuse me, number is, you're going to have to make up for that somehow, right? It's going to have to come from somewhere. So it's concerning, right? So what does it mean for the way that we see dollars being invested, not just in portfolio strategy, but as an industry, right? What are we seeing happen now? I think a few really, really important pieces to address, again, are around these R&D costs, which is at the far, the blue column there on the left of your screen. There are scenarios where there are certain exceptions from participating in selection or negotiation in the Inflation Reduction Act. One of them is around drugs that have a rare orphan designation. So if you bring a drug to market and that product has one indication for one treatment, you are exempt from selection or participation in the Inflation Reduction Act. One of our own Boston-based pharmaceutical manufacturers, Alnylam, has a product that is used to treat a pretty rare patient population called amyloidosis. And as such, about a year into their commercial endeavor, has essentially halted expanding the label for that product, because while they have compelling data to meet an unmet population for Stargardt disease, that's right, an unmet need for a population with another rare disease, continuing to invest in bringing that product to market eliminates their exclusivity in participating in the open market with no cap on how long they are commercially viable with the first product they were indicated for. As soon as they move to a second, they are no longer exempt. That's a really, really hard case to make, right? To think about giving up exclusivity for a rare patient population at a certain cost, knowing that you developed the product with an understanding that it would be able to treat other diseases and the label expansion would help fund and cover other patient populations, and that you would derive profit that you've invested and that your shareholders have invested in this case to bring that product to market. So unintended consequences in the way we're seeing R&D play out is concerning, right? I think that goes hand in hand with fewer options for patients, right? We think about, even apart from this one example of Alnylam, it plays out in a lot of different ways. One of the first reactions we saw from the investment community was first from Moody's, who issued a investor memo to all customers about a potential industry-level downgrade for life sciences. An industry-level investment downgrade for an industry sector is almost unheard of. But that's the perception of how impactful this could be for drug development. And if you're talking about companies like generic drug companies, who typically manufacture relatively low cost, relatively low complexity, very, very high volume drugs, it's a hard case to think about why to continue to compete there. You have a shorter product life cycle. It's a very competitive market, which means how you're priced is already a penny's game. And if you're not driving volume there, which is hard to create the commercial and physical and logistical infrastructure to do, you're pretty limited in what you can do. But again, these are some of our lowest cost, highest volume drugs, right? Pills. I think the way that we see the impact on innovation is at both ends of the spectrum, right? We see it in thinking about drugs that are, again, high cost, high complexity to treat rare and ultra rare patient populations. And we see it at the other end of the spectrum in treating, the bread and milk household type pills that we all use, right? So look, the idea here is not that the Inflation Reduction Act is all doom and gloom for the industry. The idea here is the economics are changing. The way that drug companies are going to invest in their portfolios, that they're going to invest in the relationships they have with centers of care and providers, the way that they're administered, the way some of the really cutting edge, early stage medical science is driven and developed, oftentimes by private equity and venture money, it is also going to change. It looks entirely different than it did 18 months ago. And I think it's really important that, we as folks who, understand both healthcare and technology are thinking about the ways that things, whether it's AI, using, AI to drive patient recruitment to expedite commercial development times and in turn cut cost in commercial development, or any number of other kind of different ways that we can leverage technology in healthcare to minimize the kind of impact this legislation is going to have on innovation, I think is really, really important. So I will pause there. I think I've got about a minute and a half left if there's any questions.
Yeah. So what do you see? Is this all baked in the cake and this is just going to happen, or are there legislative remedies that could be applied to sort of soften the blow here a little bit?
Yeah. So I think early on the public discourse was, hey, this is a good thing, unilaterally a good thing, because it's going to make drugs more affordable and it's going to allow better access and it's going to really penalize some of the bad actors out there who have been taking advantage of patients and or government programs, right? That was the early public discourse. And I think there's some degree probably of ways we can all relate to that, right? The reality is the numbers for the years for selection and negotiation of 9 and 13 feel somewhat arbitrary. In the case of small molecule, going from minimum of 15 to 9 feels entirely crippling. And the number of drugs being selected, I think, is also really, really concerning, right? So, by the time we get to 2029, 60 of the top 50, think about that for a minute, that list will have entirely turned over, plus 10 more, will have been eligible for selection and negotiation. So I think some of the ways that we could nip around the edges and still continue to implement impactful legislation is to kind of reconsider what those time horizons mean and where they came from, right? And to reconsider the number of drugs being selected. Industry doesn't bring, by 2030, industry will face up to 20 selected drugs per year. Industry doesn't bring 20 drugs to market per year that fit this criteria for selection or negotiation. So that means in about 5 years, 6 years, CMS and HHS will have the ability to essentially drive control and cost on every commercially successful drug that comes to year at 20 drugs per year in perpetuity. So I think reconsidering the depth of impact and what we're trying to accomplish through legislation is a really important way to consider how the investment community will react to it and what the impetus for continued funding and innovation will look like. Yeah.
Is there like a hidden innovation opportunity here, either from a formulation standpoint as they produce these medications, or a slight shift in the molecule, like a Prilosec to Nexium?
Yeah.
That would force innovation of sequential slight changes.
Yeah. So yes, but it's not fully hashed out yet. So for things like vaccines, right? Every year, if you take a Prevnar or whatever it is, every year when you get your flu shot, for example, it's slightly reformulated every year, right? You're not getting the exact same formulation of your flu shot every year. It's similar with a lot of HIV medications, that as the disease evolves and as human bodies evolve in response to the life-saving, life-sustaining medications for HIV, the formulation changes a little bit. And I could give you other examples as well, right? In oncology, reformulating a product for breast to lung or prostate to, whatever. But the extent to which that's going to be accepted is still a little unclear. So is there opportunity? Potentially. The program leadership in CMS would tell you that, well, that's the whole point of the exclusion eligibilities. The small biotech manufacturer eligibility for exclusion is any company where I think it's like 20% of their total income is from the Medicare program are automatically excluded. So incenting small biotech companies to invest, but only where their product is a single indication for a rare and orphan disease, right? Expanding beyond that eliminates your exclusion criteria. That's a really hard case to make. So there is opportunity, but we're not there yet. In fact, we're not even close.